Our next speaker is Professor Saher Sabri. He is associated professor at the University of Virginia. He's going to tell us about the using of mechanical devices in peripheral interventions. Welcome, Doctor.
Thank you. Meeting so far. I'll be talking about the mechanical devices and where and when and which to use. You're going to see they're going to be way less data than compared to the other modalities because these are relatively new. So why use atherectomy devices? So the concept of using atherectomy devices is built around plaque modification to decrease the plaque burden, or to facilitate low-pressure balloon inflation as a standalone therapy, basically to change the vessel compliance. And you hear this concept over and over again that you change the vessel compliance to allow you to inflate the balloon at a lower rate and less chance for dissection. Or you can prepare the vessel for stenting by debulking the plaque. There's a theoretical advantage of avoiding stenting or causing any plaque shift with ballooning and getting rid of some of the side branches. Major disadvantage is distal embolization, and it's generally recommended to use distal protection device when using atherectomy. So we're going to go directly into the types of atherectomy devices that we need to address, and these are into directional, orbital or 360, rotational, and laser. Start with the directional, which is, you heard about it some, the Silverhawk and the Turbohawk by Covidian. This is the device, and it basically, has this, see if this laser would work. So it has this cutting blade here that would cut the plaque and push it in this, packing cone. And that is the concept behind it, is basically cuts the plaque. There are different types. The Silverhawk has one inner blade and for small vessel application mostly, and the Turbohawk is the newer that has more ability to remove plaque with more blades. There's a new calcium cutter now that is more advanced. One of the issues with this directional atherectomy was not good with calcium. They have a new cutter that can actually target calcified lesions. The best use for these devices are at the origin of the SFA. As you saw, you don't want to stent there usually, and you don't want to shift the plaque and lose the profunda, popliteal artery. So any area you want to avoid stenting, and for instance, stenosis as well. And this is the device. This is one of these examples when you see the SFA origin disease, and this is the device, and this is after just using the device without any ballooning. So it can be a standalone. These are the debris that they removed, and you just heard Dr. Schmidt talk about that. You can analyze these and look exactly what's going on. So basically, this is what you remove, and we always recommend using atherectomy device with this. Use a distal protection device. Studies, the definitive LE study, you heard about it earlier, the patency rate is around 78% in the claudican cohort and around 7% in the critical limb ischemia. Distal embolization rate is still an issue, around 4%. There's some vessel perforation issues. These are all problems you have to be aware of when you use these devices. And 3% needed stenting, provisional stenting afterwards. Moving on to the orbital atherectomy, the CSI Diamondback orbital atherectomy device. It's a rotational, it's a diamond-coated crown that rotates and basically cuts mostly calcium. It's a pretty good device for calcium. Definitely changes the vessel compliance and allows you to use low-pressure balloon inflation. This is how the device looks, and this is, it's almost like sanding paper. And it basically cuts through, or basically rotates and shaves some of the calcium. This is how the device looks, and this is the console that is used to advance the device. This is a case where we had, different areas of stenosis. There's this area here that you see the calcium and a biliony pop, and this is the Diamondback device in action, and this is the active portion of it as it passes and rotates through. And they come in different sizes for the popliteal or below the knee. So this is it. This is after atherectomy, some improvement. At the low inflation, you see after PTA, it allows you to inflate the balloon only at like 3 or 4 atmosphere, and you get the results you need, so less chance for dissection. Going down below the knee, and you see here we have a, the perineal is diseased, and followed the same concept as Dr. Razai was mentioning. Try to revascularize as many vessels as possible. So going after perineal, this is after atherectomy. It looks better, but then after PTA, it's definitely more improved. But you have good luminal gain. For the AT, actually, we had to cross subintimal, so we did not usually use it if you use subintimal. So what we did is we ballooned, and you see a little bit of dissection, but there's good flow. This patient came back in 2 months for a follow-up angiogram, and you show the difference. This is the area that was treated with atherectomy, and this is with balloon angioplasty alone. So, in a study, it's called the Calcium 360. Again, you're going to see the results, the data, small single-center studies for the most part, most are retrospective. And, stenting was needed in only 7%. Lower balloon inflation was achieved, usually only 4 atmospheres compared to 9 atmospheres in the other PTA group. The other atherectomy devices, the rotational, which is a jet stream from pathway. And this basically rotates at a high speed and has a cutting blade. These materials can be dispersed distally, or there's a continuous suction so it's good for soft plaque and for instant stenosis or even thrombosis. And this is how the device looks like. And it has these rotating blades, and then you can have the blades up or down, and there's continuous suction to allow you to get rid of the debris. This is a case where this instant, you see the stent here that's completely thrombosed, and it goes all the way to the SFA origin. And this is the device, again, with the active tip. And this is the active portion of it. And this is after, and this is from my colleague Warren Swee. So this is after the device and angioplasty, and you see can restore flow. So it's one of these good devices because of the suction. It can be good for when you're not sure if there's thrombus there or not. Laser from Spectronetics is good for photoablation without damaging the surrounding tissue. It basically converts the plaque into unclot to water and vapor and CO2. It's best used for soft plaque and for instant stenosis. It really does not work on calcium at all. The other 3 devices do work on calcium. This device absolutely does not work on calcium. They say that, yeah, you can use it, gingerly in calcium, but actually it doesn't. So one of the limitations, it's relative low gain to the luminal area compared to some of the other devices. And I mentioned it doesn't work well for calcium. So this is a device. It comes with this huge machine that you have to push it through, and this is how the laser works over a wire. It actually can be worked as a crossing device as well. If you use the smaller diameter devices, can work to actually help you cross an occlusion. Usually you have to undersize, because if you oversize it, you can have dissection. You have to run saline, not contrast, to limit dissection, and you have to move really, really slow. And it's kind of quite noisy, but it's pretty effective, especially their new device that they had, the Turbo Booster, which I'll show an example of, which actually allowed to have more luminal gain. First, I'll show in a case of below the knee, and as you see, these are the tough areas to deal with. I mean, you have tight stenosis here at the tibioperoneal trunk and disease in both peroneal and PT. These are tough areas, when we balloon and you're going to shift the plaque and lose one over the other. So we did a double wire technique, have wires in both, and use the laser device to debulk the lesion here, and did the same for the peroneal. And usually it doesn't look really pretty after laser. It looks much better. And again, the whole idea is your angioplasty, you do this long inflation at a low inflation rate, less risk of dissection, and usually you have better results with that. So they have a study, the Peyton study, 90 patients with instant stenosis, and that was their main for instant stenosis, using laser atherectomy with PTA versus PTA alone, and showed better patency, 64 versus 34%, if you use the laser atherectomy over angioplasty alone. So this is probably our main use for the laser atherectomy. Pretty much everyone that comes with instant stenosis, we would use one of these atherectomy devices. The Lacey study for CLI and talked about limb salvage rate of 92% at 6 months. But as you see here, different to the other atherectomy devices, your higher use of rate of PTA, and so it's not a standalone device. It's mostly to prep the artery. Unlike some of the others, like directional atherectomy, basically it can be a standalone device. And stenting was definitely higher because there's a higher risk of dissection compared to the other devices. This is a case of in-stent stenosis, and you see here, a complete occlusion and the reconstitution distally. And this is the turbo booster, and it's basically this is the active tip here, and sits on a ramp that you push it, and you do the laser at, you try to do 4 different quadrants to get better luminal gain, and then you angioplasty alone, and you get better patency. Future studies, you heard a lot about drug-eluting balloons, and everyone is excited about them. Now try to combine these different modalities. So the definitive AR is directional atherectomy followed by paclitaxel-coated balloon. It's a pilot study for anterior stenosis. This is something we're looking forward to. And also now to compare all these different devices, there's this Liberty 360 trial that basically all FDA-approved devices, we need to look at them and compare, and follow up for 5 years. It's going to be a long trial. They're going to have multi-center involved, and hopefully we'll have some results of what's the best way to use these devices. So in conclusion, basically what do we use in our practice for the most part? So in directional atherectomy, mostly for SFA origin, popliteal artery, and sometimes for in-stent stenosis. The new device for calcified lesion, for focal calcified lesion, especially in the SFA, is pretty good. The orbital atherectomy 360 or Diamondback, it's best for calcified lesions, especially in the popliteal and infrapopliteal. It really works pretty well instead. So basically, this is mostly for calcified lesions. Rotational or jet stream for in-stent stenosis and thrombosis is probably the most used for it. But actually, and you saw a case earlier that actually can work with calcium. But it's probably the best use for in-stent stenosis. And laser, again, similar thing for in-stent stenosis is the best use. And pretty much whenever you have that, this is the way to go, to use one of these devices for in-stent stenosis or thrombosis and for non-calcified infrapopliteal lesion. Thank you.